and we'll be reaching our knowledge on the basis of every session. So today, you've already had an introduction to pain. Next, what more is there in pain? How are we going to manage pain with the armamentarium that we have? So for that, today we have an eminent speaker who is going to be enlightening us on the topic of pain management. Warm welcome to Dr. Arjun M. Pillai, who is a junior resident and also a faculty in palliative medicine at the Regional Center, Hyderabad. And he has been a person who was very close to Palim India. So he is going to enlighten us on pain management, mainly on opioids today. Warm welcome, and the floor is now yours. Please take us through.
Thank you, ma'am. Am I audible actually?
So it is showing that your bandwidth is low. So, like.
Am I audible right now?
Much better.
So, good evening to all. My name is Arjun. I am currently doing my degree in medicine at Hyderabad. So today's session is about opioids actually. So I'll be just giving a brief outline of covering today's session. One is about what are the most commonly used opioids. The next is about the mechanism of action for opioids and about the practical aspects of opioid use, adverse effects of opioids, and the prices of different opioids as such. Next slide. So I believe everyone is aware of the WHO pain ladder as such. So I will just briefly give a discussion about the pain ladder. So as you know, there are actually 4 steps in the pain ladder. So we're just limiting to the 3 steps right now. Step 1, we will be using non-opioids with an adjuvant agent, with or without an adjuvant agent. However, pain is persisting for this even opioid analysis. We get to step which contains opioids, mild opioids for moderate. Step 2 also we can use both non-opioids and adjuvants.
Dr. Arjun, extremely sorry to interrupt. Is it only for us that the voice is breaking a lot? Are the participants able to hear him?
No, ma'am.
No, ma'am, it is not audible.
Okay.
It is not audible, ma'am.
Not audible. So, Dr. Arjun, maybe we can just try switching the.
For us also the voice is.
I'll just start from the starting of the pain ladder actually. So before we go about opioids, it's paramount that all of you have a basic idea of what is the WHO pain ladder as such. So in the WHO pain ladder, there are 3 steps. Actually, 4 steps are there. So we'll be just limiting to the 3 steps. In the first step, it's about non-opioid analysis and adjuvants as such. And even if after the first step, patient's pain is persisting, we hike it up to step 2 analysis, which contains opioids for mild to moderate pain. And even if after step 2 analysis, if the pain is still persisting, we hike it into step 3 analysis. That is opioids for moderate to severe pain as such. And the basic idea of the step ladder approach for pain management is that there's a systemic approach in which we can manage the patient's pain and such, and we can hike the analysis accordingly. Let's prepare the next slide. So before we start with what is opioids, we'd like to briefly discuss our case. So this is next slide also. Okay? This is Mr. X. He was diagnosed with carcinoma larynx. He was a 56-year-old man who was diagnosed with carcinoma in his larynx actually. And when he came to us, he was complaining of severe pain, 10/10 pain, which was sharp in nature, not notating around his neck actually. And the pain was lasting for 2 weeks. And he was unable to sleep actually. So how will you be managing this patient?
Participants can either unmute themselves and interact directly, or they can put up their answers in the chat boxes. We do have a lot of responses coming up in chat box. Dr. Arjun, are you able to access the chat?
Yeah, I'm able to access it. So I saw the response. So you will just go to the next slide. I will give the response after that. Injectable analysis, superior laryngeal. So this is Mr. X situation like previous slide. Yeah. So this was Mr. X situation after the intervention as such. So the next slide, please, Mr. Priya. So what we did was, like some of you mentioned in the chat box, we started the patient on opioid. So we started with an intravenous morphine trial actually, which is not the IV morphine trial actually. So take this slide. So what we do in an IV morphine trial is that we give a patient injection morphine like a small dose. It can be the 1.5 milligram or 1 milligram morphine at every 10 minutes interval actually. And the endpoint of an IV morphine trial is that whenever the patient is completely pain-free or he is too drowsy or sleepy actually. Okay. So prior to giving a morphine trial, as you are aware, morphine can itself cause nausea, vomiting. It's paramount that we start them with and give them preload them with an injection of metoclopramide, which helps in blocking the nausea, vomiting associated with morphine action. So the endpoint is satisfactory pain relief or sleepiness action. Next slide, please. So this was the situation what happened in this case of Mr. Right? As you can see, we started at 10 o'clock, and when we came, presented his pain was 10 out of 10 actually. He wasn't drowsy, and we started with injection morphine of 1.5 milligram. So we gave each dose of injection morphine after every 10 minutes. As you can see, his pain. Dr. Fatima, I will address your concern against respiratory depression in this session also actually. So after every 10 minutes, as you can see, the pain score was subsiding. Like from 10, it became to 7, then 4, and at 10:30, it became 1. So a total of 4.5 milligram morphine was given for this patient. Next slide, please. So now the patient is having a good pain relief. He's scoring it just a 1 out of 10 actually, and we gave a total injection of 4.5 milligram of IV. Now we have to send this patient back home or to respiratory disease. So the thing is, whenever we are sending a patient back home, it's not practically possible to give him an injection morphine to be given every 4th hour. So we have to convert it to an oral medication or oral format. So how are you going to convert it to an oral form? Any suggestions or answers? Yes, I think we'll go to the next slide actually. So often as a medication, as an oral medication, we usually give it round the clock and it's an oral tablet as such. So what we ideally say to the patient is that we start it at 6 o'clock or at whatever time the patient wakes up. So half a tablet in the morning, followed by 10 o'clock dosage at half a tablet. Yeah, and 2 p.m. another half a tablet. At 6 p.m. next of a tablet. And at night, 1 tablets. And in between, we can put an SOS dosage to the rescue dosage, which called half tablet.
Dr. Arjun?
Yeah. Is there any disturbance? Can you move to the next
Yes.
slide, actually? I believe the pressure has some doubt, actually. Dr. Prakash, is there any doubt you have raised your hand in chat?
Actually, the voice is breaking.
Sorry, because the hospital is here right now. It's disturbed here actually. It will go change in 5 minutes. Please bear with me.
Sorry, sir, voice is completely.
Hello?
Yes.
Is it clear right now?
Yes, now it is okay.
Is it clear to everyone? The audio right now?
Yeah, it's fine.
Yes, sir, it's audible.
That's okay. Fine. So that's the way we go with an IV morphine trial actually. There's also another option in which we give the patient an oral morphine trial. So if the patient is opioid naive, that is the patient hasn't taken any opioids, be it tramadol or morphine or anything, we start them with a 5 milligram tablet. Also, we can consider the patient opioid naive if his total opioid dosage per day is very low actually. And if the patient is already on a weak opioid like tramadol, we have to start those patients with 10 milligram tablets every 4th hour. The next slide, please, Rupiya. Next slide. So now we'll just discuss about 4-5 case scenarios as such. So consider mixed race, we started him on tab of 5th hour since he was having adequate pain relief with 4.5 milligram injection. So we asked him to take 5 milligram tablets every 4th hour and SOS basis. So he was comparatively pain-free for the next 2 weeks. However, for the past 4 days, when he came back to us, he said that he had to take 4 extra doses of morphine actually. So the question is, what shall we do now, and how frequently would you give an SOS dose of oral morphine? I think we'll again be coming back to the stories again. Shrupiya, next slide, please. So another scenario is the patient's pain was stabilized with 10 milligram of morphine 4th hour itself. But then when he came back for a review, he told us that he's finding it extremely difficult to take a tablet every 4th hour because of his day-to-day activities and work and all. He is not able to take it every 4th hour. Though he feels that the medication is helping with his pain, he wants to know whether we can take it less frequently and whether we can help him with that. So what will you do with this situation actually? You need not, but we'll be getting back to the story at the end of when I discuss about it again. The next story, please, Rupiya. So suppose another scenario is the patient is, we'll discuss about it, Dr. Fatima, actually. The story, all the stories, solutions are also present on this. We'll get to it in the due time. So Mr. X was on 10 milligram morphine tablet 4th hourly for the past 10 months. Then he was brought to you with complaints of excessive drowsiness. So we did the general examination. And we also went for lab parameters. That time his creatinine level was found to be 5 milligram per deciliter, actually, which is highly elevated as such. So here also, what are we going to do with the morphine dosage? The next. So this is another situation which Mr. X, another patient was sent home after taking morphine 8th hourly actually. After 2 months, he was presented back to us with a complaint that he is not able to swallow even sips of water actually. So what will you do now for this patient for pain relief? So this is another scenario. So here's a lady with CA colon with was having abdominal pain and is continuous in nature and is on 10 milligram of 4th hourly, and she doesn't need any SOS dose of morphine. So the doctor who was consulting her asked her instead of taking a morphine tablet every 4th hourly, it would be better for her if she can take a patch of 25 microgram strength. So she was put on that fentanyl patch as such. However, the next day the patient came back to you saying that she had to replace the fentanyl patch just after 5 hours as it was not at all helping with her pain actually. So what will you do in this patient? So before I go to a discussion of the first scenario, all the scenarios which I mentioned to right now are the ones which we face in our OP or clinical practice on a daily basis actually. The patient having started on initial dose of opioid, having inadequate pain relief and taking extra doses of morphine, or patient coming to us saying that he doesn't like taking a tablet every 4th hourly, or who comes to us with increased drowsiness and altered serum creatinine level or altered liver function test, or asking for a patch which they feel like is not working after 5 or 6 hours, or not able to swallow. So these are the types of cases which are going to face in our daily practice as such. So let me get back to the first case scenario. So Mr. X, when we started with the 5 mg morphine tablet every 4th hour and with risky doses, he was initially pain-free for the next 2 weeks actually. So he needed 4 risky doses of morphine action. So what we are going to do now? Yes, Dr. Madhu, like you mentioned, we are going to hike the morphine dosage. Next slide, please. So whenever the patient is initiating 2 or more rescue doses, it means that the dosage at which we started the patient is not sufficient and we have to hike the dosage of morphine actually. So ideally, can hike it by 30 to 50% every 2 to 3 days actually. So we start him on 5 mg morphine. If you're hiking it by 50%, it comes to 7.5 milligram tablets actually. Or we can also hike it to 10 milligram every 4 days. Most of the time, even though we say 7.5 milligram is the required dose, it's patients find it difficult to break the tablet into 3 by 4 tablets. So conveniently, we change it to 5 milligram 10 milligram 4 times. The next slide. How frequently will you give a rescue dose of oral morphine and why? So this is related to the duration of action of a morphine tablet and also the pain response of the patient. Ideally, when, like I mentioned earlier, we give morphine every 4th hour. The reason being morphine acts for a time period of 4 to 6 hours actually. So what we usually suggest a patient whenever he started on morphine is that if his pain relief is inadequate, even after, and a T half of morphine is 1 to 2 hours actually, even after 1 hour, the pain relief is inadequate, we ask them that to take an extra dose of morphine tablet actually. We need not wait for 2 hours, Priyanka. We can just wait for 1 hour actually. So if a patient is on took his due dose at 10 o'clock, we can wait till 11 actually, so that to assess whether the pain relief is sufficient or not. If the pain relief is insufficient, we can ask him to take a rescue dose even after 1 hour actually. So the next slide. So like I believe all of you are aware of morphine as source actually. So morphine is a natural occurring alkaloid and it's obtained from the Papavus somnifera plant. And this is one of the most important opium opiate alkaloid. So the images in you're seeing in screen are of the morphine plant as such, Papavus somnifera. Should be the next slide, please. So now we'll be talking about briefly about the pharmacokinetics of morphine. I will try to address all your doubts at the end of the session. Okay. You can just put it in the chat box right now. So in pharmacokinetics of morphine, we'll be dealing about the absorption, distribution, metabolism, and excretion of morphine as such. Next slide. So regarding absorption, morphine is a weak basic drug action. So since this being a basic drug, it's absorbed through the alkaline medium of our small bowel actually. And it's hydrophilic in nature, so it has got a slow onset of action and a slow onset and a longer duration of action. Such. Next slide, please, Shruti. So orally, when we give it substitute to the small bowel actually, but sometimes sublingually we give sublingually is asked morphine is being given as to sublingually. Patients to find it difficult to take it orally. But the reason behind sublingual is that sublingual morphine has got a very low absorption as such. I mean, it has been found to be there isn't any significant pain relief with sublingual absorption. And there's also research is going about the buccal and gingival mode of administration of morphine. Another thing which you have to notice is that morphine tablet has got a very bitter taste. So sometimes the patient won't feel like taking it in such a next slide, please, Shruti. This is regarding the first pass hepatic metabolism of morphine. So whenever you take morphine orally, it goes to a GI tract and it's absorbed from the small bowels into the blood vessels. There it's passed, goes on through from the portal vein to the liver where it's metabolized, and the metabolites are then sent out through the systemic circulation action. So morphine is mainly metabolized in our liver actually, and certain minor parts of morphine is also metabolized in our gastrointestinal tract as well as the kidney. So regarding the metabolites of the morphine actually, the major metabolite of morphine is M3-GHP, and it consists of 45 to 55% morphine 3 glucuronide. And M3G recently it has been found out not have any significant analgesic effect as such. And N6G, which consists just 5 to 10% of the morphine metabolites, is the one which has got an analgesic effect. So, yeah, next slide. Next slide. So this is regarding the next story, which is Mr. X's pain was stabilized with 10 mg morphine 4th hourly, but he finds it difficult to take it every 4th hourly. So he says that he's willing to take it if you give it less frequently. What will he do? Can anyone just put it in the chat box what all you feel like can be done for this patient? Most of you are writing same answer. So yeah, we can convert the patient into a sustained release formulation actually. Next slide, Mr. Priya. We don't usually go for an 8 hourly with prescription of morphine. Actually, the reason being is that the duration of action of morphine is lasts for just for 4 hours. However, if you give the double the dosage or something during the same time, instead of getting adequate pain relief, what happens is that the patient will become more drowsy actually. So it's better if we can convert it to a sustained release formulation. And regarding the SR tablets, the duration of action is from 8 to 12 hours. So we can start it with a BT dosing like twice a day, and we can hike it to 3 times a day if needed. And the way we convert is that we actually check the total morphine return for a day. Like if the patient is on 5 milligram 4th hour tea, comes down to about 30 milligram of morphine in a day actually. So we need a total dosage of 15 milligram BD dosage, and we act accordingly. Or if it's on 10 milligram morphine, we have to make it 60 milligram morphine actually. So 60 milligram morphine per day comes to an SR formulation comes to 30 milligram BDS. Let's repeat the next slide, please. So regarding the various preparations of morphine, like you mentioned here, one are the immediate release tablets and the sustained release tablets as such. Certain centers also have got an aqueous solution of morphine so that patients or even kids, children of pediatric age group find it easy to take the solution as such. Other formulation are injections actually. So injection has got two dilutions. One, like mentioned in the slide, is 15 milligram per 1 ml, and other formulation is 10 milligram per ml actually. The next slide, please, Supriya. So this is regarding the next scenario which I said. So this patient was on morphine 4th hourly, 10 milligram for the past 6 months. Just hold on a minute actually. So So this patient was brought to you in accompanied with excessive drowsiness, and when we did the normal lab parameters, his serum creatinine was found to be 5 milligram per deciliter. So what do you suggest to be done in this patient actually? You can put it in the chat box actually. So I think I got three responses. One was to reassess the patient's pain, and other was to reduce the dosage by 50% as such. Change to other non-renal metabolism drug. Let's repair the next slide, please. So thing is, yeah, like you mentioned, morphine, though it's metabolized in our liver, it is excreted through our kidney actually by glomerular filtration. So if there's a renal impairment, the M6G, which is the main metabolite for analgesia, gets accumulated in our body. And as M6G is accumulated, the clearance is decreased and half-life is prolonged. So in this patient, there are two options. One is to increase the spacing and making the dosage TID. And other is reducing the dosage, like mentioned put in the chat box. So the other option is to put it in a renal safe opioid, like fentanyl or methadone, actually, like alternate opioids as such. Prepare the next slide. This was another scenario which we discussed about the Mr. X who went home with morphine 5 mg 8th hourly. And after 8 months, he came to us with difficulty in swallowing it. So what will you do now for the pain relief in this patient? Again, can you put it in the chat box? So I believe the general consensus is to change into a patch or IV formulation actually. Syringe driver, no. So, yeah, so routes of administration of morphine actually. So in this patient, we can actually change the patient to a fentanyl patch if possible. IV morphine, if the patient is admitted in inpatient facility or there's a way of administering the intravenously, subcutaneously, we can consider changing into a parenteral administration. Again, this is based on how the patient's general condition is and prognosis as such. And unfortunately, there are no morphine patches. Patches which we have are of fentanyl and buprenorphine, which is a lower opioid actually. Other things like fentanyl patch. So regarding the routes of administration of morphine, morphine can be administered intravenously or subcutaneously and orally as such. Now, this subcutaneous route is the one which we most generally prefer and should be. Sometimes we can also administer morphine per rectally actually. The same oral formulation tablet can be applied per rectally in certain patients who are not able to take oral. So this again depends on whether the patient is willing to be administered on morphine every day and whether the caregivers who are with the patient are willing to administer it every day. Most of the time, we either convert them to a patch or an injectable formulation as such. It's like epidural routes of administration. All this are actually much more in our hospital facility as such. And can't be practical in a home-based setting actually. Should be an example. Same with ultrasound. Exactly. So in this patient, one thing which you can do is ask the patient to take it per rectally 8th hourly action. So this is an immediate release formulation, the one which you apply per rectally, and not the sustained release formulation as for adequate pain relief as such. Other option is fentanyl patch, but again the issue with fentanyl patch is its cost and its availability. Fentanyl patch is not readily available as such, and is slightly more on the expensive side actually. So it's not much more practical possible for all the patients to afford a fentanyl patch. Next slide, please. Realistic can be considered for administration of morphine, but it again depends how the patient's general condition is and all. In certain patients, we always consider realistic placement and ask them to take morphine via the realistic. So this was another situation which I said, a 55-year-old lady with CA collar came with this abdominal pain and continuous nature and was on 10 milligram of 4th hourly. Wasn't taking any risky dose of morphine. She was converted to a fentanyl patch, 25 microgram strength. However, the next day she came back to me with stabilizer, pain wasn't subsiding, and she removed the patch just after 5 minutes. What will you do in this patient? Again, can you put it in the chat box? So, Shreya, the next slide, please. Okay. So, like mentioned in the chat, the time taken for a fentanyl patch to act is slightly a bit longer actually. So, fentanyl patch, what fentanyl does as a drug is that it forms a subcutaneous depot of drug actually. And its duration of action or onset of action is slightly bit longer. If for effective analysis, like you all of you mentioned in the chat box, it takes from about 8 to 12 hours as such. And each patch lasts for 72 hours. So like we mentioned the case scenario before, the patch which was applied was removed just after 5 hours. So whenever we are prescribing a patient on fentanyl patch or starting on fentanyl patch, ideally we inform them that the patch takes nearly 8 to 12 hours to start, and for them to take the other alternate form of analysis like tab morphine or injection morphine till there's an effective analysis with fentanyl actually. And each patch lasts for just 72 hours. That is hardly 3 days actually. Okay. And the absorption of fentanyl patch also is dependent on the skin condition and temperature actually. It has been found with slightly higher temperature, there's slightly increased absorption of fentanyl. And one major thing which we need to know about fentanyl is that since it forms a subcutaneous depot of drug, it only works for a constant pain as such. If the patient is having any fluctuating pain as such, fentanyl patch is not an ideal solution. It will be better to control the pain with morphine or any other analgesic and then converting the patient to a fentanyl patch as such. Should be in the next slide, please. So the formulations available for fentanyl are, it's either available in the injectable form or as a transdermal patch, like most of them know. And there's also an oral transmucosal fentanyl citrate, like a fentanyl lollipop as such, which also works effectively for pain. Fentanyl is also a lipophilic drug, and it's 100 to 150 times more potent than morphine. So whenever you're putting a patient on morphine and converting him into fentanyl, there's a conversion which we take here. That is, if the patient is on, suppose the patient is on morphine 60 milligram per day, that is 10 milligram morphine 4th hourly. The equivalent fentanyl patch which the patient needs is 25 microgram per hour release patches of fentanyl. So we have the next slide. So like I mentioned, whenever you're converting a patient from into fentanyl action, ideally the patient needs to get another opioid cover for the initial 12 hours. After that, only the fentanyl patch action will start. And if the patient's whenever the patient is having any breakthrough pain, we ask them to take an extra dose of morphine tablet as such. This is another situation. A 70-year-old man, carcinoma was like coming with throbbing pain in his right front of his chest, which is continuous in nature. He's scoring it at 5 out of 10 actually. He's a known epileptic and is on phenytoin, 100 milligram BD. So how are you going to manage this patient? How are you going to manage this pain actually? Any suggestions in the chat box? Amitriptyline. Okay. We are mainly focusing on discussion on opioid, Dr. Fatima. So it will be better if we can, your suggestion be very related on that topic. So going with Arjun analysis actually. Prepare the next slide, please. So choosing an opioid in a patient is, can you just hold for 1 minute? This another situation. The patient is on tab morphine 50 milligram every 4th hourly, and she attends our clinic with severe pain. We have two formulations. One is injection pentazocine, other is oral morphine tablet as such. So how are you going to manage this patient? Should be next slide, please. So whenever you say the term opioids, actually, it's a general term. It doesn't refer to any specific drug as such. Opioids are a general term which is used to include both natural occurring semi-synthetic and synthetic drugs which produce their effects by combining with opioid receptors as such. And all the opioids are actually antagonized by naloxone. Next. So whenever I consider, so you need to know about the opioid receptors as such. Generally, there are three main opioid receptors: mu, kappa, delta. Sigma is another receptor which we say when we talk about opioids, but it's not a true opioid receptor, and its action is mediated through cannot be reversed using naloxone action. The next slide, please, Shruti. So whenever we classify opioids, we classify it on the basis of its receptor interaction actually. So based on this receptor interaction, we can classify opioids into agonist, antagonist, and agonist and antagonist. Agonist and antagonist can be further classified into partial agonist and mixed agonist and antagonist as such. I believe everyone is clear with the terms of agonist and antagonist. Agonists are the ones which interact with the receptors and have an intrinsic factor forming an effect from the receptor itself. Antagonists can be of two types. One is competitive antagonists and non-competitive antagonists. Competitive antagonists are one which compete an agonist for the same receptor site as such, and non-competitive antagonists are one which alter the action of agonist by action through another receptors. Agonist antagonists are agents which have got certain agonistic action on certain receptors while having an antagonistic action on other receptors as such. Next slide, please. So if you are using a pure agonist, the pain relief will increase with as the dosage increases. However, in an agonist antagonist as
Sorry
in
for
an
that, doctor. You can continue.
however, in case of an agonist antagonist as such, there won't be. In case of an agonist antagonist as such, there won't be a heightened analgesic effect of the medication with a heightened dose. There will be a ceiling effect as such. Is there any disturbance of background noise right now? Hello? Okay, fine. So play the next slide, please. So what are mixed agonist and antagonist? So pentazocine is one of the prototype drug which we say as a mixed agonist antagonist. Like the name mentions, it has got both agonistic action and antagonist action. This is dependent on the receptor on which the drug acts. So pentazocine has got an agonistic effect at kappa receptors, while it has got a weak antagonistic effect at mu receptors as such. Morphine as such is a pure mu agonist as such. What pentazocine does is it replaces morphine from its mu receptors and it adversely affects the agonistic effect of morphine as such. The next slide, please, Rupiya. So back to the case scenario. Mrs. X, who is on 50 milligram of morphine 4th level, came to our OPD with complaints of severe pain. And we have both formulation of injection pentazocine and oral morphine tablet. How are you going to manage? Rupiya, the next slide, please. So first thing we have to do is that whenever the patient comes to severe pain, ideally we have to take a proper history to assess the patient's drug compliance. Most of the time, what we find is that patients might not be taking it every 4th hour. So find out whether the patient is took the dosage of medications correctly or whether there is any mixed dosage of such. Okay, next slide, please. And it's better, like I mentioned earlier, pentazocine replaces morphine. It's got a mu antagonistic action. So since it's got a mu antagonistic action, the pain relief won't be adequate with pentazocine itself. So it's better if we can go with oral morphine tablet formulation as such. Okay, the next slide, please. What are the serious side effects with morphine? I think when we started the morphine trial, there was a concern regarding respiratory depression as such. So we'll just go with the side effects first. Okay. So the major side effect which we see in morphine is constipation as such, and followed by nausea, vomiting, and sleeplessness and tiredness as such. And certain patients might have issue and dryness of mouth. Next slide, please. And urinary hesitation. Like you see in the side effects of morphine, respiratory depression is not mentioned as such actually. We will be talking about respiratory depression in the coming slide. So like I mentioned earlier, constipation is the major complaint with patients who are started on opioids as well. And it happens in 95% of patients and lasts long. And so what we usually do is that whenever we start a patient on any opioids, we also prescribe them a stimulant laxative like bisacodyl as such. And the dictum being that the hand which writes an opioid or morphine must must also write a laxative in the same prescription as such. The next slide, please. Now, vomiting and nausea are the other side effect which is present in patients, and it occurs in 1/3 of the patient in the first few days, and it's a self-limiting symptom. It is happening due to the stimulation of the chemoreceptor trigger zone as such. And if you're able to recall, before giving a morphine trial, we gave the patient with metoclopramide. The reason being that, next slide, please. Yeah, once more. Metoclopramide is one of the few drugs that acts on the central chemoreceptor trigger zone actually. The other being haloperidol and domperidone as such. So whenever we start a patient on opioids with morphine as such, we also prescribe them metoclopramide and tell them that they might have a sensation of nausea or vomiting for the initial 1 to 2 days, after which the nausea feeling will subside. We also give them metoclopramide, asking them that if they have any nauseous feeling or vomiting feeling, they can take it as such. The next slide, please. And the other side effect is sleepiness and tiredness or drowsiness. This also occurs in 1/3 of the patients at the initiation of treatment, and it's also a self-limiting symptom. So both this nausea, vomiting, and tiredness symptom, we actually advise the caregivers and patient regarding this and educate them that these are the side effects that can happen to them, along with constipation. And both this nausea, vomiting, and tiredness are self-limiting symptoms as such. Next slide, please. Now, what all we mentioned till now are the side effects of morphine. Right now, we've been covering about the toxic effects of morphine. So regarding toxic effects are adverse effects when the administered dose is higher than the required dose for pain relief or the patient pain is having a poor response. The major toxic effects which we see in morphine are delirium, myoclonus, and drowsiness. So drowsiness happens both as a side effect as well as a toxic effect as such. Next slide, please. Regarding respiratory depression, I think all of us, whenever we are taught about opioids in our UG days during MBBS during pharmacology, the major side effect which we were taught was of respiratory depression due to morphine actually. Shruti, can you just forward this? So what has been found out is that this is from the management of opioid side effects in cancer-related chronic non-cancer pain, a systemic review. This was published in the Journal of Pain in 2003 actually. What came out was that patients that take the medication by mouth combined with normal gastric irritation dose ensures that respiratory depression is very much unusual as such. Next slide, please. And when respiratory compromise does occur, an alternative explanation like pneumonia, pulmonary embolism, or cardiomyopathy, or co-administration of another sedative medication such as benzodiazepine must be considered. In my practice till now, I haven't seen respiratory depression occur to a patient who is on morphine as such. But in certain patients, like as the research article mentioned, there might be some other side effect might be causing shortness of breath. And in palliative medicine as such, in patients who are having shortness of breath or in respiratory problem, morphine is the go-to drug for these patients. And we also get referrals from other departments asking us to give morphine for patients who are having severe shortness of breath. Not only in a cancer setting as such, but also in severe COPD or bronchial asthma, we can also start the patients on morphine for their shortness of breath action. The next slide, please. The other major phobia with morphine, apart from respiratory depression, is that morphine causes addiction action. So, yeah, you can just forward slide. Based on research finding, one thing which came out was that the substance abuse as a result of medical use of morphine is very, very low actually. Next slide, please. And there's also confusion between physical dependence and psychological dependence, which is addiction action. Next slide. And overestimation of risk of addiction. This addiction risk is one thing which we commonly encounter whenever we are dealing with not only with patients, caregivers actually, but also with workers of other streams actually. They also say that you are making the patient an addict or there's respiratory depression as such. Next slide, please. So addiction, like the psychological dependence. What addiction means is a primary chronic neurobiological disease with genetic, psychosocial, and environmental factors influencing its development and manifestation. It is due to impaired control over drug use, compulsive use, and continued use despite harm and craving actually. Next slide, please. Physical dependence is another state in which that it's a state of adaptation that is manifested by drug class specific withdrawal syndrome. Dr. Priyanka, the mechanism of action which morphine helps in respiratory depression is that it improves the quality of improves the respiratory drive actually, and there will be less dead space ventilation action. This in turn improves the oxygen drive and helps the patient having better quality of breathing instead of rapid short breathing. Next slide, please. So regarding morphine prescription actually. So a patient is on severe pain and we are starting on a morphine actually. So how are you going to write his prescription? And his serum creatinine levels are normal actually. One thing which all of you must be aware of is the way we write an opioid or analgesics. Since morphine is a highly restricted drug, its prescription also got its own points. Prepare the next slide, please. So we have to ideally write the patient's name, age, and address, and the morphine tablets, the dosage, the standard dosage that the tablet is available, and like tab morphine 10 mg, which is one of the standard formulation in which we are the medication is available, and the dosage at which we are asking the patient to take, like half a tablet at the times also 6 a.m., 10 a.m., 2 p.m., 6 p.m., and at night double the dosage, 1 at 10 p.m., and half of SOS doses to the number of days, 10 days. The number of tablets needed for each day, 30 numbers. Along with morphine, like I mentioned earlier, we ideally whenever we start a patient of morphine, we also write them on a laxative, a similar laxative as such, like disacodate. And since the patient's opioid, we also give them metoclopramide for the initial 2 to 3 days. And when we have to write the review and also the signature name, our medical council registration number as such, and the address of the institution where we are working on. Next slide, please. Now, this is a second prescription. Mrs. X was on tab tramadol 15 milligram 8th hourly for pain. Now she has severe pain. I was started on morphine 4th hour. The prescription of this will be, should be the next slide, please. Yeah. Is this prescription correct actually? Anyone can put in the chat box actually. That was the scenario which I mentioned earlier. So this is the scenario. Another scenario. Okay, no. Any other opinion or all of them in the same word that the prescription is wrong? Okay, timings. Other than timings, anything else? What is wrong with this prescription? Can anyone put it in the chat box? Timing is one thing which came up. Is fully timing the issue? Laxative, 2 opioids, lactulose, duration, addition of antiemetic. Any other suggestion? Shruti, can you just go? Yeah, weak and strong opioids. Address, name, age of the patient. Shruti, can you just go to the next slide? Yeah. So ideally, when you are starting, no, previous slide, sorry. You have to write the name, age, gender, and address of the patient. And it's like mentioned in the chat box, we usually don't go with 2 opioids at the same time. That too, 2 different classes of opioids. Like I mentioned earlier, tramadol comes under step 2 opioids and morphine is a step 3 opioid as such. So ideally, we just prefer one step opioid actually, step 3 or step 2. We don't go with both step 2 and step 3 as such. And regarding antiemetics, like I mentioned earlier, antiemetics is only seen 1/3 of the patients. And when the patient is on tramadol, the chances of him or her developing nausea or vomiting is much more less than an opioid naive patient actually. So we did not write an antiemetic for this patient. And liquid paraffin should be replaced by tab laxative. Yeah, that's another thing. We always prefer a stimulant laxative rather than a stool softener as such. And the address and name of the doctor and the number of tablets must also be mentioned. Let's prepare the next slide, please. So this is the cost of morphine tablets. I don't know whether it's the same cost right now actually. So morphine 10 mg tablets, it costs about 3 rupees 50 paise. While tramadol is slightly on the expensive side, 24 to 50. And fentanyl patch, 12.5 micron fentanyl costs much more higher, like 250 to 400 rupees actually. And methadone is another drug. It comes in step 3 analysis, but I believe there's another session regarding methadone. Actually, it also costs about 4.5 actually. As you can see clearly, fentanyl is a highly expensive drug. And another issue with fentanyl is that it just works for 3 days. So when you are putting a patient on fentanyl, for 1 week itself, it might cost you about 800 rupees for the patient. And most of the patients in our country belong to a lower financial strata or lower social income situation. And it's not practically possible for these patients to afford fentanyl every 3rd day as such. So next slide, please. Yeah. The slides are over actually. So regarding doubts, can I just put it in the chat box? I think I missed a couple of them. I'll try to address them.
Thank you very much, Doctor. The main thing all of you have to have in mind is that going through with these case type of thing is very, very useful. As he mentioned, so the whole presentation has given you an idea of what are all the possibilities that you can face. And especially few things, what I would like to insist is that the slide which had how should you prescribe. That is very, very important. The name of the drug and writing the timings, 6, 10. See, it may sound, oh, why? even if you write that, you have to explain to them that it has to be taken in those timings, and then making sure that night they take one tablet instead of the half tablet what prescription is started. And after that, prescribing the antiemetic and the laxative is a must. I would stress that again and again, because we know these two side effects are very, very common. And if you don't, if you write a prescription without those two, I would say you're not justifying what you have done. So all those factors, everything is important to have in mind and be clear and do it so well. The beneficiary, that is your patient, gets the total benefit out of it. So that, I would say, could be your take home. Like or the rest, like the interactions, all those are also very, very important. But that prescription, how you write every word, what was mentioned, is very, very important to keep that in mind. Go ahead, doctor, with the chat thing. Are you happy to read an answer, or you want us to read anything for you?
No, ma'am, I will read the chat and
Okay.
answer.
Okay,
I
then,
believe
go
there
ahead.
are 3 questions which I see. So regarding the best site to apply patch, actually, there isn't any specific site as such we say the best site to apply patch. Ideally, we apply it at the shoulders or the arm or the chest region or the thigh region, actually. Another thing which we need to note is that whenever we are applying a fentanyl patch, it's always one thing which we do is that we write the date and time at which we apply the patch, actually, so that whenever we see the patient next time, we know at what time the patch was applied and when we have to change the patch, actually. Also the dosage of the patch, because the patch as such is a transparent thing and there isn't any mention of dosage in the patch, actually. So we ideally, after applying the patch, we apply a sticker over it, like a tape over it, in which we mention the detail at what time, at what date, and what strength of the patch was applied, actually. Now, regarding Manush, yes, methadone is very much available in India, in our country, actually. Methadone has got 2 formulations. One is the syrup formulation, other is a tablet formulation. Both these formulations are available in our country, but I don't believe it's available in all the centers. It's limited to certain centers only. But methadone is available in our country, and it can be preferred for patients who are having nephrotoxicity as such, rather than fentanyl. The reason being, methadone is much more cheaper compared to fentanyl.
You will have a full session on that. Don't worry about it. You will be, again, same as we have dealt with today. You will be going through with sessions of examples and where and how and when you can use it. The entire thing will be given. And one thing about fentanyl patch, one more thing what I would like to add is, yes, see, if you are going to see, if somebody else sees the patient also, if everything is written clearly, no ambiguity is going to be there. So what the doctor mentioned, that writing it clearly, will be helpful. Even if A sees and starts, B comes and sees the patient. So everything is clear there. So normally everything is mentioned about the patch on it. That's all safety. With these type of drugs, you have to be doubly sure that everything is right and clear. Anyone comes, there's no even the slightest query on any aspect of it.
So the next question is, if patient is supporting this upper limit, how long can we keep giving patches? Actually, there isn't any upper limit as such, but ideally in an end-stage patient or patient who's in an end-of-life situation, we don't prefer a fentanyl patch. The reason being is that the patch takes at least 8 to 12 hours to act. And if the patient is in his last few hours, it's advisable to manage the patient with injection morphines or as such, rather than a patch as such. In last 2 or 3 months, we can consider a fentanyl patch for the patient. Again, the financial situation varies from patient to patient as such. And no, there isn't anything saying that we must apply the patch at the site of pain itself. Fentanyl being a transdermal formulation, it works entirely throughout the body. So if the patient is having chest pain, it doesn't mean you have to apply in the chest region or such. We can apply it in any part of the body as such. The next question is how can we manage breakthrough pain in a patient on fentanyl patch? So what we practically do is that whenever a patient is on a fentanyl patch, actually, we actually ask them to take the rescue doses of morphine whenever they are having severe pain, actually. So based on the number of dosage of morphine tablets which they're taking, we can adjust or titrate the dosage of fentanyl patch accordingly in these patients. Other is what is the maximum available dose of morphine per day? There isn't any, I am pretty much unsure whether there's a maximum limit of morphine ceiling effect. What we say is that it's a patient to patient basis, it changes. Certain patients might be having a pain relief with 30 milligrams, some might need 60 milligram per day, some might even need 300 milligram morphine per day. So there isn't any maximum allowable or permissible dosage of morphine. What we ideally do is that whenever the patient is on morphine, the way we hike is that we also look for any side effects in these patients. If these patients are not having any side effects, we can hike the morphine tablet accordingly. Can opioids be prescribed to a patient who's living alone or without care? Yes, we can prescribe opioids in these patients also, but like ma'am mentioned, methadone is one thing which we ideally do not prefer in such a patient. Actually, we usually prefer to have a reliable caregiver methadone. We will be having a detailed session on methadone, but morphine we can prescribe for patients who are living alone and without care. These are, we usually find these patients much more in our practice than we expect actually, and we usually put them on morphine. They have adequate pain relief with morphine actually. While converting IV to oral morphine dose, we have to start a time for it depends on. So when we are converting IV formulation of morphine to oral medication, it is dependent on how much IV medicine of morphine went for that patient. It doesn't mean that a patient who got pain relief with 6 mg, 7 mg of injection morphine needs to start on 5 mg itself. What we do is that if the patient is having adequate pain relief with 7 mg of morphine, we convert it into either 5 milligram, which is known as an undercorrection, or we can switch into a 10 milligram formulation, which is an overcorrection. And based on that, we can manage the pain of such patients. If a patient comes with a pain score of 10, we have this given morphine. So again, ideally, we say that we have to start the patient on morphine, but again, it is dependent on the cause of pain and the nature of pain actually. Pain score is a subjective thing. Pain is a subjective symptom actually. Way one person scores pain will be entirely different to way another person scores. So even though we say it's 10 out of 10 pain, we have to start morphine, it's always depend on the nature of pain and what all medication was the patient taking on prior to this. If the patient wasn't taking any pain medications, is coming a severe pain, sometimes a non-opioid analgesic like an NSAID or even a weak opioid like tramadol itself can give adequate pain relief for such patients. Is we use fentanyl patch for complete 72 hours actually. What we do is, like I mentioned earlier, we have to mention the date and time, and once the 72 hours is over, we change it to another formulation actually. But the thing is, once we change the patch, there is a constant preparation level of fentanyl in the bloodstream actually. So for the next, there isn't. So when you're continuing patches for 3 or 4 patches, we need not worry about the initial 12-hour delay period actually. Can a general so a general practitioner can prescribe morphine once they are trained actually in the opioid use and how to prescribe it as such. Other than without an opioid, like without a training about opioid, actually we are not able to prescribe morphine or any other opioids as such. Sub-Q morphine, ideally we have to administer in a healthcare facility as such, but in the setup we are working with, we can also administer morphine sometimes in a home care basis. We do that here in our center actually, because patients in home care might be having severe pain and sometimes we have to administer the morphine in the home visits as such. But it's better if there's a healthcare facility backing for these patients. Is morphine ER, SR, CR? Yeah, I believe they are all the same actually. That just depends on the company or trade name which release. Extended release or chronic release or sustained release are the same, same different names or same formulation. Many high-tech cancer hospital donate morphine.
Not a morphine in their pharmacy. They are prescribing tramadol only for severe cancer.
So, Dr. Manoj, it's a challenge which we are still facing even after this much years. Even there has been even after the NDPS Act, which was even like addressed again, the challenge is still persisting, not only in our state, but in multiple parts of our country actually. So ideally, we say the patient who is having severe pain needs to start on morphine, but it's not possible almost. Can every anesthetic? No, not all anesthetists can't get a license for all more. You need to be trained for that actually. I am not an anesthetist by training. I am just a general medicine doctor who's doing his specialty in palliative medicine. So it's not necessary that all anesthetists can prescribe morphine as such. So do we give sub-Q morphine infusions actually? Yes, we give morphine infusion. I believe one of the answers in my previous questions regarding how if the patient is not able to take orally was syringe driver actually. I believe there's a session that will be taking care of subcutaneous infusions and syringe drivers. In that, it will be clearly mentioned how, when, and where you have to consider subcutaneous infusion, the modes of delivering subcutaneous infusions, and where all we can give subcutaneous sites actually. The next question is, so naloxone, how to identify morphine overdose is what we usually do is we look for the other toxins of morphine, whether the patient is delirious, whether there is any myoclonus, the respiratory rate as such, as well as the pupillary dilation. Based on that, we can get a better idea whether the patient is having morphine overdose or not. And naloxone is also readily available as such. When we change over from fentanyl patch only, we should the dose we give it patch on. So when we change from fentanyl to morphine, what we have to do is that we have to consider the equivalent morphine dose. Like I mentioned earlier, when you're converting from morphine to fentanyl, the equivalent of 60 milligram of morphine per day is 25 microgram of a fentanyl patch. So ideally, when you're converting back from fentanyl to a morphine formulation, we have to change it back in the same way itself. And we can also ask the patient to take liberal doses of rescue doses so that we can adjust the dose accordingly. What is PTA, patient control? So patient control analgesic is a thing in which it's not, I believe I haven't seen it much, but I've read about it actually. In this, we give a patients themselves can administer morphine doses per them, and they have got an IV line drips connected to them. And by pressing the button on that switch, they get a small dose. I believe it's 1 mg. I'm not exactly sure of the dosage of morphine which gets. And patients able to administer morphine by themselves. In this way, the patient feels much more empowered so that he's in control of his pain and his power pain medication as such.
Just about this, if you want, just sorry to interrupt. This patient controlled analgesia is totally, because having used it, I thought I would just add on more information. It is entirely, you need the device. You just can't just with a syringe driver. You will have the device, and it is the drug, everything comes in a specific pack attached through an infusion, and it is all programmed. The device is programmed. It will give a continuous infusion, and on top of that, you will have another button. So if the pain score, for example, goes above 5 or 8 by 10, then the patient presses. Everything is pre-programmed to give 1 milligram. It's that dose, what the patient dose, what is programmed in the device, that will only be delivered. That is patient-controlled analgesia. As the doctor mentioned, the patient has an upper hand. See, sometimes you have to wait for the nurse to come and give. Even all that is avoided. And then patient has a better control of pain. So that is our main thing. Again, it is when the cost effectiveness, because the device, everything is expensive, and you have to have the medication in that particular form. So overall, we all have to see what is possible, and so that many patients are able to get the benefit. Yes, it's nice. You have to know what is PCA or patient control. It can be said as a PCA, patient controlled analgesia. So that is what it is. Thank you. Go ahead.
So there is opioid tolerance. So what we do in opioid tolerance is that we usually go for prefer opioid rotation actually, or opioid step down in certain patients. That is, we convert from one form of opioid to another form of opioid, like from morphine to fentanyl and methadone as such. So sometimes we decrease the opioid formation from morphine to tramadol as such. But tolerance is a very rare phenomenon as such. I haven't seen much patients who have developed opioid tolerance as such, and we just know the less than 0.1% of something patients develop opioid tolerance is what I know of the situation actually. Other thing which I feel one missing was that someone asked in the chat box how much pain relief is adequate pain relief, and at what time we have to ask patients to take rescue doses actually. So it's a subjective thing as such pain we say. So a patient who is having a severe pain or 8 by 10 pain, even after taking morphine, the pain is still 8 by 10. It's ideal that they take a rescue dose of morphine. And like I mentioned earlier, the dosage required for each patient varies actually. So based on that, they have to titrate the dosage of morphine. It doesn't mean that every patient will have the same kind of response to morphine as such. The response to morphine also changes. So in patients in altered LFT, what we do is that we are just like in altered renal function and altered liver function, we titrate the dosage of morphine and we do two things we can do. One is to increase the frequency, like instead of going every 4th hourly, we can go with every 6th hourly or 8th hourly as such, based on the altered liver function as such, or we can change the dosage accordingly. But that doesn't mean that every patient whose LFTs are deranged needs to be given a 6th hourly dosage of morphine. It again depends on patient to patient. I've seen certain patients who have got altered LFT being given morphine 4th hourly is having adequate pain relief without any adverse effect or toxic effects as such. So again, instead of going the theoretical part, it's better we take a consider practical and see it as a case by case basis.
Clinical assessment. You see the patient, give something, review. This one can be managed only in that way. Constant, regular review. You give something and then don't wait. Like, see, for example, your breakthrough pain prescription is given for that. Okay, 6 o'clock, 10 o'clock is written. But even in spite of taking the 6 o'clock dose, 10 o'clock, 8 o'clock patient is in agony. Are you going to see him struggle and leave him there like that? No. So like that, and then it's an individual variations are there, which you have to have in mind and take everything on a patient-to-patient basis. And individual titration is also required at every point of time. And many of your queries, you have a session, one more session on difficult pain, and also you have an entire session on methadone. And the question, all anesthetists use pain. I am an anesthetist and intensivist. I will not be given permission to have morphine and give. There are specific things. You have to have obtained palliative care accreditation, and not only just the course, you should have done some in-house training for a certain period of time. Only then you will be able to see, or everyone know you have to see to believe. And many of the myths of morphine, it will cause addiction, all that, no, for oral use and what type of use it is. So that is what decides addiction prone. So when it is used, especially the gold standard medicine for pain relief in cancer is morphine. So these type of things are also there. So all those have to be borne in mind. And once you do this training and do some in-house training for 5 days or 10 days, and there are many places where you can do that, then you are eligible to apply and obtain morphine. Like it can be in a clinic or in a hospital or anywhere, but you should have all the tick boxes for all the requisites. Once all your requisites are ticked, then you will be able to have. Once you attend the in-house training, you yourself will know what are the plus and minus of it. And so that will give you more confidence to get and use it also.
There are 2 more questions. Okay. Sorry, Fatima, even I don't know how to manage a patient if he's an heroin addict. I haven't seen it till now. I have no idea how we're going to manage such a patient. If I get any idea, I'll get back to you regarding heroin addict patient. Other is regarding rescue dose. Yes, we always write a rescue dose in our prescription action. So whenever you're writing a morphine prescription, we write the timing ideally over 4th hour as such, and we write an SOS dosage as such. And then night and double the dosage. We always write a rescue dosage in our prescription as such.
Your prescription is not complete if your rescue dose is not written. Okay, as I was mentioned, no, like those type of things. That's what these prescriptions, name, dose, timing, the antiemetic, the laxative, breakthrough pain, all are part and parcel of that one prescription. And then your question about the heroin addict, no, like, see, those type of patients, like what you have to do is, what was it like? If it's a heroin addict coming for pain relief, or what? Can you rephrase or add on something more to your question? What was that?
Yeah, hello, ma'am.
Yeah,
actually, if we have a patient who's a heroin, I would like to know how we manage the pain in those patients. I think that the pain tolerance should be a bit higher, right?
Yes, see, they're opposite of opioid naive patient. So the same dose you start, it may not be effective. again, as it was mentioned, no, this pain is an individual subjective phenomenon. So you have to keep a closer eye. You have to keep appropriately titrating the dose and checking on a regular basis. And all adjuvants may need to be added. So it will be on a one-to-one basis you may have to do. See where you will be able to. So that's all. The individual variation will be there.
Yeah, ma'am, one more question. So at this point of time, you won't consider thinking about any de-addiction management, right?
See, that's all. That de-addiction management, see, that type of patient, if he's going to come for palliative care or so ideally, no, de-addiction is an entirely separate cup of tea. So that one has to be sorted out before you go on regular. So those type of patients will be more prone to misuse. So you are giving someone who can misuse. So you have to be very careful in those type of patients. So even everything has to be had. You have to think of all those things. So those type of patients, it's like you are giving him an opportunity to misuse more.
Yeah.
So you have to be very, very careful with those type of patients. Individually, you have to consider, maybe do the de-addiction and then start. But at the same time, if it's an acute situation, you will have to manage, and it's like literally you have to check the compliance. Every time you give, whether he swallows, you have to see by your own eyes. You can't just give it to the patient and go, and he can misuse it in any forms. He can just hold on to everything. So all those have to be had.
Thank you.
Welcome. Anything else? Are there anything more in the chat box?
Shripi, there's a case discussion also, right?
Yes, we do.
I think already we have overshot our time.
Sorry. Yes,
Yeah.
too much of interesting questions came up. Let's go over there.
Dr. Rahul?
Yes, ma'am.
Yeah.
So, good evening, everyone. Myself, Dr. Rahul, Senior Resident, Himalayan Institute Hospital Sciences from Dehradun. Now, today's case presentation is of a 54-year female. She is a diagnosed case of metastatic carcinoma right breast. Her IHC is triple negative. Presenting complaints, fungating ulceroproliferative region involving whole right breast since 2 months, severe pain in right breast, bleeding from right breast lesion. Coming to history of illness, the patient was apparently well 2 years back in 2020. Then she noticed a lump in right breast, which was initially in size of pea, gradually increasing in size up to size of orange. There is no history of skin involvement, pain, nipple discharge. The patient was initially evaluated outside and was diagnosed as case of carcinoma breast and received 2 cycles of chemotherapy. But patient defaulted for almost 1 year due to COVID pandemic. From last 8 months, patient was on Ayurvedic medication for the same. 4 months back, patient had progressive increase in the size of lump associated with skin involvement with fungating ulceroproliferative lesion involving almost whole of the breast. The fungatic lesion associated with pain. Pain was severe in intensity, pin and needle sensation type, radiating towards back and was not relieved on analgesics. It was associated with bleeding and foul-smelling discharge from the lesion, decreased appetite, and disturbed sleeping pattern. On examination, she was ECOG PS2, pallor present, no significant cervical or SCF lymph node, BP 130/90, pulse rate 96, SpO2 98% on room air. Systemic examination, bilateral air entry present, no added sound, per abdomen soft, non-tender bowel sound present. On local examination, right breast fungating lesion involving whole of the breast with complete distortion of nipple areola complex associated with bleeding and seropurulent discharge. Right axilla showed a lymph node of 3 into 3.5, hard fixed, non-tender. Treatment and significant investigation on routine examination. Her HB was 6 gram, PLC 15,800. Platelet 2.8 lakh, LFT, ALP was raised about 302, serum creatinine 0.8, sodium 128, serum potassium 4.5 milligram per deciliter. Chest X-ray was done and ultrasound was done due to her financial issues. Chest X-ray was suggestive of bilateral lung nodules, and USG showed multiple hypoechoic lesion in both lobes of the liver, which was suggestive of METs. Now on treatment, injectable antibiotics, support, blood transfusion, antiseptic dressing, pain management with NSAIDs and opioid and other supportive measures was done. Psychosocial aspect, financial constraints. Husband is a farmer and he runs his family with his monthly salary without any other source of income. Patient's family support structure is not that great. Psychosocial distress, depression, and existential crisis issues related to meaning of life. Effect of pain on sleep, mood, social, and recreational activities. Coming to medication, tag augmentin 625 milligram, one tab thrice daily after meal for 5 days. Tab signoflem, one tab thrice daily at 8 a.m., 2 p.m., and 8 p.m. Tab gabapen NT 400 milligram, half tablet twice daily, 10 a.m. and bedtime. Tab morphine sulfate 10 milligram, one tab 4 times a day after meal for 2 weeks. Syrup dexorin 2 TSF twice daily. Tab ondansetron MD 4 milligram, one tab SOS to chew like a chocolate if there is nausea or vomiting. Here Dulcolex tab is not mentioned, but we have prescribed tab Dulcolex 2 tab at night. Reassurance, relaxation, and psychological support, etc. Now, main concern is pain and bleeding, financial problems, psychosocial issues, depression and anxiety, sleep disturbances. Summary: 54-year female diagnosed case of metastatic carcinoma right breast with fungating lesion in breast, chronic pain and bleeding. Now, points for discussion is further management for patient pain management. Is the patient right candidate for palliative care? Does the patient need systemic treatment or end of life care? Psychosocial support, counseling.
All of you can just type in or unmute and ask. He's asked questions which will cover the whole of palliative care session. But at least from today's point of view, pain management and what other things, is she a right patient for palliative care? Go ahead and either unmute and ask, or you can type in the chat box. Either way is fine. Mastectomy along with chemo and pain management. Okay, these options they will type there.
Is the main issue with the patient is that she is non-compliant. She is coming from 150, about more than 150 kilometers from hilly area. So we know that she will not come again and again for any type of treatment.
So
or
pain
she will
management,
not continue with chemotherapy.
no, pain management wise, like will you be able to give her medications? For how long can you give, and can she not send somebody else and get her medications? At least to
So
keep
we
her
have given her
comfortable.
option, and yeah, we have given her option to she can send any of her family members or any relative for pain medication if she is not able to come, or otherwise if further she will come to our OPD, we are planning for any kind of palliative radiation to the local area for bleeding, and we will go for palliative chemotherapy for her systemic metastatic disease.
Exactly, palliative radiotherapy and something with the lesion, if it is going to help her, that will help her a little bit with her pain relief also. So that we can try, as you said, no, like giving her an option of sending someone from her family, because we can't give morphine to anyone and everyone. So she will have to send someone who will get all documentation right. Especially with morphine, all of you have to be doubly careful, okay? We want to do the best, but do the best in the right way. So complete, clear, legible documentation. And so whenever you start them one thing, even if you're going to ask someone else from the family to come, they have to come with all details. And only then it will be safe for you to dispense and make sure that it is going and getting used in the right way forward. Over and patches, low dose. Okay. Yes, ideally, that's what supportive care, as someone has mentioned in the chat. We have to, if possible, direct them to someone who will be able to support them financially or in any form. That is what, it's more of a team working effect. That is what will be beneficial for the patient as such. So only getting in touch with any organization or charity groups which are willing to help them. And then once you connect the dots, like if either the patient to them or they are willing to come and see when she's visiting for her review opinions or something like that, that will be the way forward. Psychological support, evaluation and support is very, very essential. So all these native treatment also, no, so if we can't say no because it's all their belief and faith. At the same time, we have to tell them how watchful they can be so that the disease per se doesn't get aggravated, or especially with wound care and all, you can tell them to make sure that they keep an eye on that. They keep on top of it with doing dressing and things, so that other forms or things don't hamper the progress. And so that those things have to be taken care of. We have to tell the patient, that's all, we have to teach them what is right and what should be done, what has to be seen regularly, on what should they keep an eye on stuff, all that has to be done regularly. And made sure they understand. Not that we are not telling them not to do anything else, but they have to be aware whether the disease progress or the ulcer is worsening or anything like that. That in those situations, not only the patient, you have to educate the carers also. Good. Anything else specifically anybody would like to ask? Otherwise, we would say that we've had a good session with obtaining enough knowledge, and also very happy that all of you participated very well in showering your questions, I would say. The questions were coming one after the other, and hope most of your queries have been clarified too. Anything else anybody has? Or else we can, if there's no burning question to be answered, we can conclude our session, maybe, Sri Priya.
Yeah. Any final words from Dr. Arjun?
Actually, sorry for the audio disturbance from my side, actually, because there was such other disturbances here. That's why the issue with the audio. And also, extremely thankful for Pillai for providing me this opportunity to take a session again of this. Also for managers. Thank you, many thanks.
Thank you. We got the audio disturbance and things sorted. Initially, that's why we told you, because it's an important session, and you were able to sort it out, and then we got going on the right track. That's fine. As long as something defect is rectified, no problem.
Thank you, Dr. Arjun, for joining us and enlightening the entire audience with such important informations. And we do look forward for more sessions from your end as well. And thank you everyone for making the sessions interactive as the days go by. So with a very positive note that the next session is also going to be as interactive and informative as this with the Dr. Mary Abraham joining back us. This is Sri Priya along with Dr. Arjun and Dr. Radha Venkatesan signing off from the Tips Echo Hub. See you in the next session. Till then, everyone, take care, be happy, be safe. Bye-bye.
Thank you.